Okay, so now our next topic is oxygenation. So oxygenation or oxygen is the basic, one of our basic needs as a person. So of course, it will become one basic need of the patient as well. So let's discuss what are the things we need to remember and to know about oxygenation as nursing assistant. Then let's go with the terms that we need to remember regarding or related to oxygenation. So first we have hypoxia. Okay, what is hypoxia? Hypoxia means that the cell do not have enough oxygen. Okay, as we all know, the cells can live only if they are having oxygen. Like a person, okay, like us people, we need oxygen to live. Okay, so thus cells also needs oxygen. So without this oxygen, there is a condition called hypoxia. You have also tachypnea and bradypnea. You know that. What are the normal respiratory rate? It should be 12 to 20 breaths per minute or cycles per minute. So more than that, okay, it's called tachypnea, and lower than that, it is bradypnea. Apnea, it is a lack of breathing. A means absence, lack or absence of breathing. Then you have also hypoventilation and hyperventilation. When you're talking about hypoventilation, the respiration is slow and shallow. So, like this, okay, very shallow breathing. That is hypoventilation. Hyperventilation is rapid and deeper breathing, like this. Okay, so that is hyperventilation. So dyspnea, this means difficulty or labored. So that is difficult or labored or painful breathing. You will see dyspnea in a lot of respiratory conditions like tuberculosis, asthma. What else we discuss? COPD. We have also cane strokes respiration. For cane stroke respirations gradually increases in rate and depth. Then they become shallow and slow. So it means that the respiration or the breathing is irregular. Then breathing may stop or there will be an apnea for 10 to 20 seconds. Orthopnea means breathing deeply and comfortably only when sitting. So usually this happens, okay, only for those patients with COPD. If the patient is sitting, they can breathe well. But without in sitting position, the patient have difficulty breathing. Then you have Kussmaul's respiration. So for Kussmaul's respirations, there is very deep and very rapid breathing. You will see this in a diabetic complications like DKA, diabetic ketoacidosis. Then what are the ways to meet the oxygen needs? So first we have positioning. So this we can do it as independent nursing intervention. We don't need any order from the doctor or from the nurses. We can do it alone. So if the patient have difficulty breathing, we can position them, okay, as early as possible to ease or to help them to breathe well. So breathing is usually easier if you position the patient into semi-Fowler's position or Fowler's position or high Fowler's position. Persons with difficulty breathing often prefer orthopnic. Okay, orthopnic is the one with the pillow like this. Then deep breathing exercise. For deep breathing exercise, you inhale with your nose and you exhale with your lips. This will expand your lungs. Okay, so if your lungs is expanded, it will help you to breathe well. And it will not also help to expand your lungs, but it will help you to relax. Okay, some patients, they have only experiencing tension or anxiety. That's why they have difficulty breathing. So to help them, okay, to ease their breathing, you tell the patient to do deep breathing exercises. Then pulse oximeter, okay, pulse oximeter or checking the oxygen saturation. is helping us also to get the oxygen saturation of the body or of the patient. So the normal oxygen saturation is 95 to 100%. Okay, we already discussed that in our vital signs discussion. Then we have also oxygen therapy. So guys, we have different types of oxygen devices that you can see in the hospital. Okay, the question is, can we initiate oxygen therapy? Ideally, we are not allowed, as nursing assistant, we are not allowed to initiate oxygen therapy. However, if there is an emergency, okay, you can initiate oxygen therapy. Of course, patient will die, of course, and then the nurses are so busy. You can initiate that, but initiate oxygen on the lower levels only, like 2 liters, okay? In that way, you can help or you can save the patient. So we have different oxygen devices. You have the nasal cannula or prong. You have the simple face mask, partial rebreather face mask, non-rebreather Venturi mask, high flow nasal cannula, and you have the non-invasive ventilation mask. Now, let's go first with the nasal cannula. So what are the concentration? How many percentage of oxygen it can give you? There is 40%, okay? Then the flow rate. The flow rate is how many, okay, you will see in the oxygen, there is a ball there. You will see how much you can put the oxygen. For nasal cannula, okay, you can put the oxygen 2 to 6 liters only, until 6 liters. Then what are the advantages of nasal cannula? Okay, nasal cannula, it's safe and simple and enables movement, especially eating and talking. If you notice, if patient is with face mask, how the patient will eat, okay? The nasal cannula is only in the nose, so it is easy to eat and talk. Then, what are the disadvantages? For disadvantage, guys, possible headaches and dry mucous membrane. So any oxygen therapy, guys, not only nasal cannula, the complication of these or the side effects is you will have a dry mouth, okay? Dry mouth. Why? Because it will, the oxygen will increase the dryness of your mouth. So what you are going to do, okay, you should ask the patient always to always rinse the mouth if indicated, if he can rinse the mouth. You have also high flow, let's go first with high, you have also high flow nasal cannula. No, let's go first with simple face mask. For simple face mask, guys, concentration is 35% to 50% of oxygen it can deliver. Then the flow rate is until 6 to 10 liters. Okay, most the advantage is it will give you oxygen as well. The disadvantage is it will cause skin irritation. Okay, for example, you have this mask. Okay, it can irritate the surrounding area because there is pressure. Might have, it will cause also so there is a mask here and it's here. So it can cause skin irritation. It might cause also pressure ulcer. Why? Because there is a garter here, like the mask. Okay. So to prevent that irritation, you can put gauze, okay, before the mask, or here also you can put gauze to prevent the pressure ulcer. Then you have the partial rebreather mask, okay? For partial rebreather mask, 40% to 70% oxygen it can deliver, then 6 to 10 liters per minute. Then advantage is it will give you more oxygen. Then same disadvantage is the same, skin irritation and discomfort. You have also non-rebreather mask, 60 to 80%. Okay, it will give you the highest possible oxygen concentration. Okay, 10 to 15 liters per minute. Then the disadvantage is skin irritation, discomfort, necessity for tight seal. Okay, you need to make it tight, okay, to make it work. Then you have the Venturi Mask. Do you know that among all the oxygen devices, Venturi Mask is the most accurate? Okay, take note of this. Venturi Mask is the most accurate among all the oxygen devices. Okay, the concentration is 24 to 60%. Then the flow rate is 2 to 15 liters per minute. Okay, then the disadvantage is skin irritation, discomfort, necessity for tight seal. I will tell you why it is accurate later when I show you the picture. Then you have also, if all of these four will not work, nasal cannula, nasal cannula or prong, partial rebreather mask, non-rebreather mask, and Venturi Mask. Okay, if this four will not work, okay, we will proceed to the high flow nasal cannula. For high flow nasal cannula, it will give you a concentration of oxygen of 50 to 92%. So that is too much. So that is higher dose of oxygen. The flow rate is 15 to 60 liters per minute. This one, we are using a machine already for high flow nasal cannula. I'll show you later. Then, disadvantage, not allowed with maxillofacial trauma, complete nasal obstruction. Why? Because we are putting here. And then suspected skull fracture. Why? Because of the higher dose of oxygen, okay, it can cause too much pressure, severe pressure that can affect these conditions. Then, if this high flow nasal cannula will not work as well, then the patient will proceed to non-invasive ventilation. So for non-invasive ventilation, guys, it is a delivery of oxygen via a face mask, and therefore eliminating the need of endotracheal airway. So endotracheal airway is the patient will be put on intubation. Before that, the patient will first put with this type of oxygen device because it is non-invasive. However, there's a lot of side effects, like there will be skin irritation also because you know, guys, this type of mask is with tight seal. Okay, it's very, very tight. Okay, it's very, very tight and it's connected to ventilator. Okay, but it's non-invasive. That's why it's called non-invasive ventilation. There is ventilator, but through mask only. It's not inserted on your mouth. Okay, this one will cause, I saw a lot of patients. I saw this one, non-invasive and high flow, it is used to COVID patients. I saw a lot of COVID patients with this type of ventilation device or oxygen device who has a lot of this pressure ulcer here, here, and here. Okay. So what we are putting a protective pad here to prevent the pressure ulcer. Okay. So you will see here there is a nasal cannula, okay, nasal cannula. Then you have also the partial rebreather mask, okay, partial rebreather mask. If you see partial rebreather mask, okay, partial rebreather mask is this with the bag, okay. You have the non-rebreather mask. You have the non-rebreather mask. You have the simple face mask. Okay, if you notice, simple face mask has no bag. And you have the Venturi Mask. Okay, as I've told you, Venturi Mask, okay, has, you will see there is, this is called the color-coded, what do you call this? We are putting this, okay, there is a designated LPM or liters per minute on each. So some color, there is 2 liters, other color is 4 liters, 6 liters. That's why if you put that, there is an accurate amount of oxygen being supplied to the patient. Because for a certain amount of this color-coded, what do you call this? I forgot how we call it. Color-coded connector, you were able to give an accurate amount of oxygen. So that's why Venturi Mask is the most accurate. Okay, for this non-rebreather mask, guys, and partial rebreather mask, partial, it means that the oxygen is partially, what happened is if you inhale, guys, there is a valve here. Okay, I'll show you. Guys, this is a valve, okay? If you inhale, guys, if you inhale, it will open. This valve is open, okay? So the air inside the bulb, the bag, okay, will go inside. So that is inhale. If you exhale, there is let's see. If you exhale, okay, see, in this part, there's two opening here. If you exhale, okay, the air will comes out there. Non-rebreather is with a higher dose of oxygen supplied than the partial rebreather. Okay, so that is the different types of devices, oxygen devices. Then we have also on the left side, this is called the high flow nasal cannula. So this high flow nasal cannula, okay, it's connected with a machine, okay, like a ventilator. It's connected with a machine ventilator to give you a higher dose of oxygen. And on the right side, this is called the non-invasive ventilation. Okay, this one is connected with the ventilator also. Okay, non-invasive because it's non-invasive. It's not put inside. So these are the oxygen devices. Now, what are the oxygen flow rates? Okay, so for the oxygen flow rates, guys, when we are manipulating the oxygen flow rates, when giving care and checking the person, always check the flow rate. Okay, for example, when you're doing vital signs, you check the flow rate. Okay, maybe the flow rate required for the patient became lower or higher, so you should inform the nurse in charge. Then tell the nurse at once if it's too high and too low, so they will adjust. Then oxygen safety, you do not give oxygen. Okay, you assist the nurse in providing safe care. Always check the oxygen level when you are with a near person, okay, when you are checking the person. Oxygen tanks and liquid oxygen systems are example. Report a low oxygen level to a nurse. So if you're checking the oxygen level, okay, you will see there in the oxygen, I'll show you the oxygen. I'll show you this one when we have this face-to-face class, okay, to fully understand this. Then follow the rules of fire and use of oxygen. Guys, it's not allowed to smoke on the area where there is oxygen because it will cause fire. Then never remove the oxygen device. Make sure the oxygen device is secure but not tight. Check for the signs of irritation for the oxygen. So this is behind the ears, under the nose, around the face and the cheekbones. Keep the face clean and dry when a mask is used. Then never shut off the oxygen flow unless it is directed by the doctor or by the nurse. Do not adjust the flow rates unless allowed by your state and agency. You know, some agency or some hospitals, they will allow you to put oxygen, but ideally, guys, in general, okay, we are not allowed as nursing assistant. This is the job of nurses. Tell the nurse at once if the flow rate is high or low. tell the nurse at once if the humidifier is not bubbling. Okay, if you'll notice in an oxygen device, there is a bubble. Okay, a device where there is a water and it's bubbling. If that device, that is called humidifier. If that humidifier is not bubbling, it means that it needs to be replaced. Secure tubing to the person's garments following the agency policy. Make sure there's no kinks in the tubing. Of course, if it's kink, okay, how the oxygen will go into the patient. Make sure the person does not lie on any part of it because it will clog or it will kink the oxygen tube. Then report signs of hypoxia, respiratory distress, or abnormal breathing. If you see the patients even the patient is having oxygen device and still the patient is having dyspnea, hypoxia, respiratory distress, having abnormal breathing, you should report to the nurse immediately. Why? Because might be it's not effective to the patient. They might change the oxygen device or they will intubate the patient. Worst comes to worst. Then give oral hygiene as directed. So this is the one I've told you, because the result of having oxygen in our oxygen inhalation is you will have a dry mouth. Then make sure the oxygen device is clean and free of mucus. Then another ways to meet our oxygen needs is incentive spirometry. Okay, if you had operation before, might be you used this before. So this is called incentive spirometry. Okay, incentive spirometry, this will help you to expand your lungs. Okay, so how you will use it, guys? In the mouthpiece here, okay, you need to inhale. Okay, you need to inhale, not exhale on that mouthpiece. You need to inhale. And then if you inhale, you will notice that the ball here or on the left side, the yellow part, it will go up. Okay. At first, if you had surgery because you receive anesthesia, you will not make it up. Okay. Okay. It's very difficult for you to make it up because still your lungs is still anesthetized. So, but day by day, times will pass by, then it will go up because your lungs is regaining its normal function. Okay, so as long as you're making it up, like up to 4, 5, or 5,000, it means that your lungs is fully expanded. Now, another topic is collecting sputum, guys. Okay, as nursing assistant, we can collect sputums also. Sputum is a mucus from the respiratory system. If we have cough, if we have infection of the lungs, then they might ask us to get our secretions or mucus. So ideally, we are getting this, okay, especially for those patients who have tuberculosis. Ideally, we are getting this early in the morning. Make sure that the patient rinse their mouth with water only, no brushing of the teeth. Why? Because it will alter the result, okay? So tell to the patient, that's just deep breathe. 1, 2, and then cough, okay? Don't put the saliva because saliva is different from sputum. The sputum is coming from the deeper part, okay? Don't put saliva because they will disregard that. Put the sputum, okay? Then they will check on that on the laboratory. Put that on the sputum specimen bottle and then put it on a biohazard bag, put the label for the patient and send it to the laboratory. What is hemoptysis? Okay, sometimes you will see hemoptysis on that. Hemoptysis is there is a bloody sputum. Okay, there is blood in the sputum. Some patients, they have hemoptysis if they have tuberculosis. Okay, there are patients with COPD or those who have this, the throat is pressurized because of too much coughing. Okay, it might result to hemoptysis. Like COVID patients, because most of them are coughing a lot. Okay, they are having this hemoptysis. Okay, now let's go with the artificial airways. So if we're not able to manage with the oxygen devices, okay, if the patient will not able to tolerate this, okay, we will resort to artificial, we will end up to this artificial airways. So guys, artificial airways keep the airway patent open and unblocked. Okay, the process of putting these artificial airways in place is called intubation. Intubation. So we have different types of artificial airways. Guys, you have the oropharyngeal, you have the endotracheal, and you have the tracheostomy tube. So, on the left upper part, okay, you will see that is oropharyngeal. Then, endotracheal, you will see on the upper right part. Okay, endotracheal. And on the lower middle part, that is called tracheostomy tube. Tracheostomy tube. Okay, tracheostomy tube. So these are the types of artificial airway we have. Excuse me. Now, so let's go with the tracheostomy tube itself, okay? For the endotracheal and the oropharyngeal, okay, most of the time this is inserted by the anesthesiologist, okay? All of this artificial airway, these are inserted by the anesthesiologist, okay? The anesthesia doctor, okay? So let's talk about the tracheostomy tube because this is related to our practice. So for tracheostomy tube, let us first know what are the parts of tracheostomy tube. Guys, you have the inner cannula, okay? You are seeing this inner cannula. Inner cannula, this is the part of tracheostomy tube that can be removed from the tracheostomy itself, okay? So this inner cannula, this is the one we are cleaning, guys, the inner cannula. Then other parts of tracheostomy tube is the faceplate. You have the outer cannula. You have the shaft. This is the one inside, okay, of the trachea. You have the fenestration. You have the cuff. You have the pilot balloon. Okay, this pilot balloon, guys, this makes sure if there is tracheostomy in place, the balloon should be inflated. Okay, so how they are inflating the balloon? They are getting a syringe, okay, getting a syringe, putting an air to that syringe, and then injecting an air, 10 cc air on that balloon. Okay, it means that balloon will, it will help to maintain the tracheostomy in place. Then, how we will assist in tracheostomy care, guys. Guys, as nursing assistant, we can assist in tracheostomy care together with the nurses, okay? So what are the frequency of doing this tracheostomy care? We should do it, guys, as daily or every 8 to 12 hours or PRN. If it's blocked with sputum or with secretions, we should do it PRN basis or as needed basis because if we will not do it, it will block the airway and the person will be in trouble, or the patient will be in trouble. Then cleaning the inner cannula to remove the mucus and keep the airway patent. Nurse tells you what cleaning agent is needed. Actually, guys, this hydrogen peroxide, it's not used anymore. We are using now normal saline only. Normal saline. I'll repeat, we are only using a normal saline solution. Then cleaning the stoma to prevent infection and skin breakdown, and applying clean ties or a Velcro collar to prevent infection. Okay, what is Velcro collar? To make sure that the tracheostomy is in place. Okay, so we will do this tracheostomy care face-to-face in our face-to-face class. Okay, you will have hands-on on it. Then we have also suctioning. Okay, so for suctioning, guys, suctioning is, it is the process of withdrawing or sucking up fluid or secretions. We are doing this for those patients who have a lot of secretions that can clog the airway. Okay, so if we will not do this, the patient will desaturate. So what is desaturate or desaturation? Desaturation means the oxygen saturation of the patient, which should be 95 to 100%, it will decrease, it will go down. So that is called desaturation. So we should do it regularly. So before doing suctioning, we should hyperventilate the patient. How we are doing the hyperventilation? We are ambo-bagging the patient. Then we have 3 routes of suctioning. First is you have the oropharyngeal. This is called the oropharyngeal. We are suctioning only the oral cavity. Then you have the nasopharyngeal, okay, suctioning the nose. Then you have the lower airway ET and the tracheostomy tube. Okay, so this one on the left side, this is suctioning the tracheostomy tube, and the other one is suctioning through endotracheal tube here. Okay, you have the tube here. So you're suctioning there. So what are the measures or the nursing considerations we should be taking note of this when we are using the suctioning technique? First, review the procedure with the nurse. Know what you are to do. Okay, some agency, they are allowing you to do suctioning. That's why I will teach you how to do suctioning. But some hospitals, they will not allow you because it's nurse's job. So first is report coughing and signs and symptoms of respiratory distress. Of course, if the patient is too much coughing, the patient, you see the patient is desaturating, then the patient might need suctioning. Suctioning is done as needed, not on a schedule. Then, follow standard precautions and bloodborne pathogens. Guys, you need to wear gloves, okay? Sterile gloves when doing this because, okay, you are touching an inner portion of the skin, especially in the tracheostomy. It is sterile and it will prevent you also from touching the secretions. Then sterile technique is used to suction ET and tracheostomy tube. This helps prevent microbes from entering the airway. Then you have also, the nurse tells you the catheter type and size needed. If the catheter here is large, so you need to use also a suction catheter which is large. Then needed suction supplies and equipment are kept at the bedside. Suction is not applied while inserting the catheter. Okay, while putting the catheter inside, guys, the suction, it's not pressed. Why? Because if you press it, you will suction the secretions. You are going to press it if it's already inside. Okay, you press it if the suction catheter is already here. Okay, I know it will be difficult for you. I'll show you a video, okay, for this, so you will understand it fully. And we will do is also in our face-to-face class. Then the catheter is inserted smoothly. This will help prevent injury to mucous membrane. A suction cycle for adults taken no more than 10 seconds. So each suction, guys, it's only allowed for 10 to 15 seconds, not more than that. Why? Because if you suction the patient for 1 minute, okay, the patient will have difficulty breathing as well. Okay, so only 10 to 15 seconds, not more than that. For infant, it should be not more than 5 seconds. Then another is catheter is cleared with sterile water or saline between suction cycles. Okay, we are using a sterile water or normal saline to clear the secretions. And then the nurse waits for 30 to 60 seconds. you need to wait for 30 to 60 seconds when you want to suction again. If you saw that still you need to suction the patient, you need to wait for 30 to 60 seconds so the patient will regain his oxygenation. Then the suction catheter is passed no more than 3 times. So 3 suctioning at a time. Okay, 1, and then wait for 30 to 60 seconds. 2, wait for 30 to 60 seconds. Okay, still there is secretions, then suction for the 3rd time. Not more than 3 times, guys. Then you need to insert the catheter for about 4 to 6 inches far only. Okay, 4 to 6 inches far only. Then before doing that, okay, you need to check the vital signs of the patients and the level of consciousness. If there is a drop in vital signs or abnormality of vital signs. Then we have also mechanical ventilation. So mechanical ventilation, this is where the tracheostomy tube, okay, or the endotracheal tube is attached. Okay, so this is the machine. This machine is handled by the so-called respiratory therapies. I'll repeat, this machine is handled by respiratory therapies. We are not manipulating this device because we are not trained about this, even nurses. Okay, doctors only and respiratory therapists are the one who is manipulating this device. If it's alarming, guys, you should call the nurse in charge immediately. Okay, or first, before you call them, of course, you assess the patient. It will alarm if maybe the tube is disconnected. Okay, it will alarm maybe there is no battery. Okay, so check first, assess first before you report to the nurse in charge. Okay, then after you assess, then you can report. Then you have the chest tubes. Okay, I told you the chest tubes is to drain the fluid and blood, air from the lungs and heart and esophagus. Usually for those patients who have pneumothorax and hemothorax. So I told you what is pneumothorax. Pneumothorax is the air in the lungs and hemothorax is blood into the lungs. So this is all about oxygenations. I will show you, I will send you also video for the skills related to this so you can understand it fully. Thank you for listening, and we will proceed with the next topic.